Good evening and welcome to Pandemics and Politics. This is a socialized remotely signature event brought to you by Harvard's Office of the Vice Provost for Advances in Learning and socialized remotely.harvard.edu. Our pair of panelists, Dr. Tom Frieden and Professor Jeffrey Frieden, discuss the political economy of public health from their perspectives as a former CDC Director and a Harvard Professor of Government. Politics and economics have changed the course of the COVID-19 pandemic, and the pandemic has changed the course of politics. Why has public health become a political football in the United States? Why has global public health become the focus of international conflict? Dr. Tom Frieden is a physician with advanced training in internal medicine, infectious disease, public health, and epidemiology. He's one of the world's top experts in tuberculosis, tobacco control, and health policy administration. Tom served as director of the Centers for Disease Control and Prevention from 2009 to 2017, and commissioner of the New York City Health Department 2002 to 2009. His work made New York City's tuberculosis control program and overall health department models for the world, established effective programs in India, and improved morale, effectiveness, and impact at the CDC. Tom is now president and CEO of Resolve to Save Lives. Jeffrey Frieden, Tom's brother, is professor of government and chair of the government department at Harvard University. He specializes in the politics of international monetary and financial relations. Jeff is the author of Currency Politics, the Political Economy of Exchange Rate Policy from 2016, and with Menzies Chin of Lost Decades, the Making of America's Debt Crisis and the Long Recovery in 2011. Frieden is also the author of books on global capitalism, world banking, and Latin American political economy, not to mention the co-author or co-editor of over a dozen other books on related topics. His articles on the politics of international economic issues have appeared in a wide variety of scholarly and general interest publications. So without further ado, let's begin our discussion of pandemics and politics. Jeff, the virtual floor is yours.
Thank you, Jonathan. Welcome, everyone. It's great to be here. And this evening, over the course of the next hour, we hope to be able to bring together Tom's decades of expertise in public health and my similar decades of expertise in analyzing economics and politics, to try to make some sense of what's going on in public health, both here and abroad. Tom, it's great to see you.
Jeff, great to be here. You know, we don't often do things together at work. In fact, as far as I know, this is the first time in nearly 20 years that we collaborated on something. And that last time really is front and center to my memory of our work together. It was actually my first time testifying in front of the New York City Council after I had become Commissioner of Health. And the topic was very controversial. And since I have a big brother who's an expert on politics, I sent my draft statement to him for revision, and he made great revisions. I thought they were terrific, and made it much punchier, much harder hitting. And I proudly went into City Council and I read it word for word, and I looked up brightly at City Council, and the chairman said to me, "Commissioner Frieden, in my 25 years in elected public service, that is the most offensive testimony I have ever heard." So we hope we won't offend you, but we look forward to the discussion in the coming hour.
Boy. Well, that was cruel. Those who can't do teach or something like that. Listen, I work on international monetary and financial relations. You can't possibly expect me to understand anything as complex as New York City politics. But never mind about that. It's a beautiful background you have there. The greatest view in the world. It's making me very homesick. So how are things back in Brooklyn?
Well, they're getting back toward normal. New York City has really made tremendous progress. New York State under Governor Cuomo has made great progress. We've had more than a month of less than 1% positivity, and they hit 100,000 tests in a single day a few days ago. So we're seeing cases, and interestingly, they've had some clusters in parts of the state, and they rapidly surged in. We're all worried about what's going to happen when university kids go back and start socializing outside of campus and having parties. So we'll see what happens over the coming weeks and months. But it's a remarkable difference from the peak of the pandemic in April and May.
Right. I remember talking to you back then, and there were sirens going, but we could hear them talking, and you told us going all day and all night. It was unreal. I mean, unlike anything I'd ever seen. Was it Did it remind you, had you ever seen anything like that?
Well, it was just horrific. It was, as you say, this is, I think, how many New Yorkers will remember this time as the time of sirens, all day, all night. And every one of those sirens are really representing someone being brought by ambulance to the hospital, many of them never to go back home.
Right.
I guess the other catastrophic situation I've been in was Ebola in West Africa, where the economies were in free fall, and the risk of explosive spread was enormous. The fatality was very high. You had really gruesome scenes where in the treatment units, there weren't enough staff to remove even the dead bodies. So it was a horrific situation there. But the kind of situation that we saw in New York City in April really is not something we ever anticipated would happen in this country. Our fear was always something like a pandemic influenza, which could cause something like the 1918 pandemic, but we always thought, well, we'll have ventilators, we have antibiotics, we can keep people alive. But if you look at the peak of the fatality in New York City, it rivals that of the peak of the 1918 pandemic fatality rate.
That's amazing. Well, Ebola at some level was controlled. I know that some of the models that you've talked about were anticipating million or millions of deaths, and so it was controlled. This seems to have been, at least from the outset, something of a failure in terms of controlling or getting a handle on what was happening with the coronavirus. So what works in public health, and why is it so difficult to get it right?
Well, every different pathogen is different, and some are easier to control than others. SARS and MERS were really hard to control, but controllable. Ebola was really hard to control. You had to get everything right, but it was controllable. COVID may have been controllable if it had been found early in China. But by the time it was spreading widely, there was no way that it could be stopped. And by early to mid-February, it was clear to those of us in public health that this was going to become a global pandemic. There was still a lot that was not known about it. But public health is, like politics, the art of the possible. And the art of the possible very much depends on what the pathogen, it depends on the environment, it depends on political will, it depends on organization. And we do have a way of thinking about impact in public health in terms of the different influences on health. And I think maybe I'll share a screen for this. This is one way to think about how you can have the most impact. And at the bottom of this pyramid are the socioeconomic factors: poverty, education, housing, inequality. One level above that are things that change the context to make individuals' default decisions healthier. Above that are long-lasting protective interventions like vaccination. Above that are clinical interventions like medicines for high blood pressure, cholesterol, diabetes. And above that are counseling, education, encouraging people. Interestingly, the largest impact is at the bottom of that pyramid, the more political aspects. The smallest impact is at the top. Doesn't mean you shouldn't do it. You have to do everything that you can to reduce impact. This is that same pyramid applied to COVID-19, the same bottom line: more poverty, more crowding, more inequality, more spread. In terms of the context, more crowding, more ventilation, more contamination, more spread. Long-lasting protective interventions, well, vaccination and increased health resilience. Clinical interventions like oxygen, intensive care, and steroids. And counseling education, what we call the 3 Ws: wear a mask, watch your distance, wash your hands. So there are ways to think about public health systematically, but one of the things that has been really interesting to speak with you about over the years, Jeff, is to understand more about why things happen and don't happen. From a practitioner standpoint, it looks very personal, because Mayor Bloomberg understood public health, and therefore we were able to get a lot done. But I understand that the analytics are really important. And one of the things that public health people aren't very good at sometimes is thinking about what is actually driving the decisions that are being made. We sometimes have this naivete that if we just say what needs to be done, it'll happen. And we're so surprised and outraged that it doesn't.
Well, it's interesting because talking with you over the years has led me to realize that social science is a lot like medicine in some sense, which is you have a patient before you, which is a problem, and you've got literature that says something about the millions or hundreds of thousands of patients and the generalizations and regularities that you observe, and they give you some guidance, but they don't actually tell you what to do in any individual case. So there is the broad regularity of politics and economics, and then there are the cases that you deal with. What I'm struck with, though, and maybe this is a little too simplistic, and you can correct me, is it seems that we were unprepared for a pandemic of this type, or a pandemic of any type, even though there had been discussion of it. I remember hearing discussion about it. I remember you talking about it 8 or 10 years ago. So is that correct, or is that just a misperception on my part?
No, the world was definitely underprepared for this. And there are many aspects of it in the US and globally that were preventable. The fact is that we are inevitably going to have another threat, and it could even be worse than this one. What's not inevitable is that we continue to be so underprepared. And one of the things that's very challenging about public health generally and epidemic prevention specifically is that when we're successful, nothing happens. And so how do you get politicians to buy into funding something that may not happen before the next election, and that is going to compete with other funding priorities, and which they may never get credit for or blame for? And that is really a conundrum. And it's the case within US politics. It's also the case globally. There's been tremendous progress in many areas of global health over the past 10 or 20 years in HIV, tuberculosis, immunizations, really good progress, saving millions and millions of lives. But preparedness just hasn't worked well. It's general, it's about general public health capacity. You can't count things quite as well as bed nets or patients treated for HIV. And it's not a threat to the US in the way that drug-resistant tuberculosis is, that you can see it more specifically, concretely. Today there are patients to be treated. It's more theoretical. And getting support for that to be sustained is really hard. After Ebola, during Ebola, we were able to get a major initiative called Global Health Security, $1 billion to do preventive activities around the world. And with that, we laid a really good groundwork. We showed where the gaps were, what could be done to close them, how much was needed, and it was pretty clear. We need about $5 or $10 billion a year for about a decade to make the world dramatically safer from epidemics and pandemics. And that's going to mean laboratories and trained staff and disease tracking systems and rapid response teams. We know what's needed, but whether we'll be able to get the resources for that is far from clear.
Right. Well, $5 to $10 billion a year sounds like a lot, but I think we now know that compared to the costs of pandemics, so really of any sort, it's trivial. Economics is usually called the dismal science, but in some ways, political economy is even more dismal, because the reality is that politicians, their job is to get reelected. And I don't say that in a dismissive way. If you don't get elected, you can have the best will in the world with the best ideas in the world. If you don't get elected, you're not going to be able to put them into practice. So politicians have to get elected and reelected. The problem with public health, in many ways, is, as you say, it's invisible when it works. And it's also very long-term. You set up a vaccination program for diseases to protect people over the next 15 or 20 years. You prepare for a pandemic that might happen at some point in the next 10 or 15 years. You work on sanitation or housing to avoid things that could happen over the next 20 or 25 years. And 10 years is an eternity for a politician, especially when there's an election coming up, and there's always an election coming up. So the politics imposes a short-term time horizon on politicians, and public health is, I think, along with a few other things, like water supply and sanitation, a quintessential long-term investment. So it's in a way, it's almost a puzzle that it ever gets done. So I guess one question I would ask in trying to identify why public health sometimes is done well, again, along the lines of thinking about regularities rather than individuals, why in some circumstances are these public health initiatives funded and supported? Things like vaccinations, things like preparedness, and in other instances they're not. You can think about that within the US across different kinds of interventions or cross-nationally. A lot of countries did a lot better than us. So what's your experience tell you about what some of the substantive sources of success in public health are?
Well, first, I can remember a much more positive interaction that we had on work. When I got my first big job was running tuberculosis control for New York City. I was 31 years old. It was the biggest outbreak of multi-drug resistant tuberculosis the US has ever had. And in fact, there were people telling me that it couldn't possibly be controlled, not for another 10 or 15 years. And you asked, you were then out west, and you asked James Q. Wilson, what should my brother do? He's got this big outbreak on his hands. And I've never forgotten the answer, which was he needs to have people outside of government pushing him to do the things that he wants to do. Otherwise, they won't get done, or even if they're done, they won't get sustained. And this has led to really the structure of many of the initiatives that I've been part of. What we have done in successful initiatives is threefold: strengthen the public sector, strengthen civil society to push the public sector to do the right thing, and strengthen objective monitoring so that you can keep everybody honest if it's not going well, and so you can defend progress if it is going well. And there are success stories. You mentioned water and sanitation. New York City, we have, as they like to say, the champagne of municipal water supplies. We have great water here, but we didn't always. And it was really in the late 1800s that the business community realized, wow, if we don't fix this, we're not going to be a competitive city. And they took over a bunch of land in the Catskills, and we have great reservoirs. In tobacco control, working with Mike Bloomberg and his philanthropy, we've been able to implement programs like tobacco taxation, more of which is needed, but some of which has been done, smoke-free places, banning tobacco ads, plain packaging of cigarettes that have made an enormous difference. Smoke-free places, those interventions have already passed policies that will result in around 40 million fewer deaths around the world. So very successful with that simple model of strengthen the public sector, strengthen civil society, that James Q. Wilson point, and establish a kind of objective monitoring. Because in public health, unless you're really making an effort to monitor something, you're not going to know if you're making progress.
Well, stepping back a little bit, just as background for those who don't know, James Q. Wilson, Jim Wilson, was a Harvard professor who then moved to UCLA. I was at UCLA. My first academic job was at UCLA. He was my colleague there, and before I came to Harvard. And he was undoubtedly, he's passed away since then, but he was undoubtedly the world's leading expert on bureaucracy. And what he was saying to Tom was based on some basic principles of political economy that I think are crucially important to understand public health and lots of other public policies, which is there's sort of a rule of thumb or a commonplace in understanding politics and political economy, which is that generally speaking, concentrated organized interests win out over diffuse interests. So if you have a few tobacco companies or drug companies, they've got a very, very strong stake in tobacco control or in drug pricing or in whatever it may be. Now, there may be only a half a dozen of them and 330 million consumers, but the consumers aren't organized and the companies are. The concentrated interests usually win because they organize. And so Jim's point, which I think is a central point in understanding public policy, is that if you can get people in the public in the mass public, in civil society, so to speak, to organize around some of these public goods like tobacco control or pollution control or public health, you have in some ways a counterweight to the concentrated interest that may be pushing in the other direction. How'd that work with tobacco, though, Tom?
Well, there's a group called the Global Health Advocacy Incubator, and they work with partners all over the world. And in New York City, when we passed the Smoke-Free Air Act, we had waitresses and bartenders saying, "This is my lungs. You know, you may see this as your place of entertainment, but it's my workplace, and I don't smoke at your workplace. You can't smoke at mine." It also changed the narrative. Communications is very important. We actually did polling on this, and it was very clear that making clear that secondhand smoke kills was a winning message. And there was no answer. In fact, a different city council leader who was objecting to this told me years later that when we introduced this legislation for Smoke-Free Air Act, we had a waitress who was pregnant talk about what it meant to her that this is the job she had to get to support her family. She was pregnant and her child was at higher risk of low birth weight and serious problems because she had to come to work and be smoked on every day. And he said that was an unanswerable objection.
Right. So presenting it as the direct interest, self-interest of workers being impeded by those who were smoking was a crucial turn. In a way, with tuberculosis came to the fore when people started getting worried about catching it on the subway or on the streets. It had been, I guess, endemic in the population or at a low level, but when it was a threat, it got some attention. So I think that's crucial. Again, going back to the pandemic, you can certainly see today that being caught in office overseeing a bad response to a pandemic is no great shakes. You're not going to do very well if you are caught out by a pandemic, and especially if your response is ineffective. So it seems to me, again, this is imposing a little bit of political science on you, but one of the ways that policymakers over the years have devised to deal with this, recognizing that at some level in the short run, they don't really have the right incentives to deal with long-term threats, but they need to deal with them because who wants to be in office during a pandemic? They establish independent agencies. They establish independent agencies in economics like the Fed, and in public health, they establish the CDC. So not to question the importance of leadership, but the reason the CDC is an independent agency, in my view, and I think the view of most political scientists, is that politicians recognized at a certain point that they needed an agency made up of trained personnel who weren't going to be pulled and hauled by day-to-day politics and were going to try to do what was right in the long run for the country's health. So that's a nice ideal. And I guess the question I have to ask, not to be too blunt about it, is what the heck happened to the CDC?
Well, it worked for 74 years. And what we've seen over the past 7 months is really unprecedented. We've seen a sidelining and an undermining of CDC. Blaming the CDC for failure in this pandemic is like blaming someone who was tied up and encased in cement for failing to swim. If you look at the record, Dr. Nancy Messonnier, who I know, she is the head of the public health, is very specific, just as there are different fields in academia and medicine. So if you want someone who works on respiratory infectious diseases that spread rapidly between people, like flu and COVID, Dr. Nancy Messonnier and Dr. Ann Schuchat are actually the two leading experts in this country. Dr. Schuchat has done this for something like 30 plus years, Dr. Messonnier for 20 years or so. And this is what they do with their lives. They are the real experts in it. And Messonnier, who heads the National Center for Immunization and Respiratory Disease, was spot on. Early on, January 26th, she says, we have to behave as if this may be a pandemic. And if the government had actually acted that way and done exactly what we said, we have to behave as if this is a pandemic, they would have ramped up testing, ramped up protective equipment, educated people, begun the studies that we still don't have some of the answers on, and we would be in a very different situation. Through the month of February, when all of us were trying to learn more, the information was vague, you had kind of a fog of war reality about it, she said we have to be humble. It was a perfect statement of what we had to do, because there are principles of what's called risk communication, which I'll get to in a moment. And then February 26th, she says, disruption to everyday life may be severe. And that's pretty much the last time you heard from CDC, because the decision was to quote, not make people panic by not telling them how bad it was going to get. Well, within the next few weeks, we'll have officially 200,000 people in this country killed by COVID. In fact, we've already had more than 200,000 killed because we've missed some of the diagnoses. But the fact is that in public health, the way to get people to come along is to tell them what you know when you know it. And there are 5 principles of risk communication. Be first, be right, be credible, be empathetic, and give people concrete, practical things to do that will protect themselves and their family and their community. Now, if you think about those 5 things, I'd say the administration is batting 0 for 5. In fact, it would be pretty hard to do worse than they have. Were they first? No, actually, and the talk about restricting travel to China, actually 50 countries did that before the US. Be right, no comment. Be credible, no comment. Be empathetic, you can look at the tapes of that when the president is asked, what do you have to say to people who are worried about this? It was a stunning answer. And give people practical things to do. Well, we learned with time that masks are really important. That was not known initially, and there was a shortage initially. But that's true because there's so much virus in people's mouth and upper respiratory tract early in the infection. It's very different from SARS. SARS is, in fact, the exact opposite. You don't get highly infectious until you're really sick. With COVID, when you're really sick, you're not nearly as infectious as you are when you're not sick at all or in the first day or 2 of illness. And because of that, masks are so important, and the evidence that masks work and reduce the spread has just been growing and growing. So it's clear they're low cost, they can help us get our economy back, and yet they've been politicized. So my question for you, Jeff, is, it wouldn't have been hard for the administration to get this right. They just had to organize well, follow the standard principles, and it would have been a plus politically rather than a minus. Why didn't they?
Well, I want to get to that, but first I want to go back a step because you talked about the right response, and looking around, it seems like there were countries that got it right. Germany seems to have gotten it right. I mean, I don't know all the details of the public health system there. South Korea, Taiwan, is that correct? I mean, are there examples?
Yes, I mean, South Korea, Singapore, Taiwan, Iceland, New Zealand, Australia, though they're having some struggles now, Germany, European country, hit before we were hit. They have a death rate that's about 1/5 ours per capita. Right. Now you can say Asia's different, and South Korea has hardly any deaths at all. Singapore is a really interesting case study because they have an excellent public health system there, and yet they had a huge problem. The epidemic will prey on any weakness in society. And they had these dormitories with hundreds of thousands of migrant workers. And when COVID got into those dormitories, they ended up with tens of thousands of cases. But because they had a great public health system, they said, oh, we know what to do about that. We're going to build locations for them to come outside. We're going to provide them with food and entertainment. We're going to keep them there, and we're going to do everything we can to control it. So they were having 3, 4, 5 cases a day. There's a population of 5.6 million. 3 or 4 cases a day outside of the dorms and thousands inside, and they were able to keep it separate, and they were able to adjust what they called, instead of lockdown, circuit breaker, to limit economic damage while limiting the spread of the virus. So there have been much better responses, but there have also, as you and I have discussed sometimes, look at the UK or Brazil or Mexico, you've seen some really bad responses by governments that didn't follow science. I like to say that the governments that were guided by public health and supported public health did better. And I think that's generally true, but why did they?
Yes. So, well, Canada, just as another example, has a death rate that's between 1/3 and 1/2 of that of the United States, and it's very similar to the U.S. in many ways. So it seems to me, and this is speculation, eventually perhaps we'll get to know a little bit more about what was going on inside the administration, but at the time, I think the feeling was that if we turn this into concern about a pandemic, it will have a devastating effect on the economy. And not just through lockdowns and government policies, but as people get scared about the spread of a pandemic, it will shut down the economy. I think we know, we've talked about this, there are studies that show quite clearly that the economy started shutting down long before there were any government policies to shut it down because people were scared. You have a potentially deadly disease, no one knows how to get it, and there's no treatment and no vaccine. People stopped going to school, people stopped going to work, people stopped shopping. And so I think the fear was, if we make this into a scary, sort of statement about what's to come, and or adopt policies which are extreme or they regard it as extreme, it'll scare people, it'll shut down the economy. And so in a way, it's attempting to balance the economic impact on the public health impact. Now, I know what you're going to say. You're going to say if they'd done the right thing from the start, it would have been better for the economy. And that's, obviously a crucial point. This is the kind of thing that we might want to find out. Would people have known that at the time? Was that a reasonable conjecture to make? And then the other point is there's a term that we use, which is not only in politics, but another thing is called gambling for resurrection. If you know that you've got one outcome that's really horrible and is likely to take place, and you can gamble on another one that might be better but is low probability, maybe you gamble on the low probability better one. And so if the administration is saying, we have a strong feeling that this is going to really have a devastating effect on the economy, well, let's try something else because we know we can't stand that. We're in an election season. So that would be my attempt to understand. Now, again, individuals matter, policies matter. I do think that the fact that the CDC and other technical or technocratic agencies had been sidelined relatively early on was really a problem. And it is, not to get too partisan about this, but it is interesting that many of the countries that have done absolutely worst in this pandemic have been countries that we would regard in political science and political economy as having populist leaders. No one really knows what populist is, but we sort of know it when we see it. Countries like the UK, the US, Brazil, Mexico, these are countries that did extraordinarily badly, I think. And it may be a distrust of science, a distrust of experts. We've heard that many times. I think the point is that, again, politicians think about the politics. It's their job. And in this case, thinking about the politics, perhaps in the short run, led to a series of decisions that turned out, I think, to be disastrous for everyone in the long run.
So I think the more important question is, what do we do now? Now, not just in terms of COVID, but in terms of the next and inevitable public health risk. We've worked now with a set of Democratic and Republican senators to have a bipartisan suggestion. We call it the Health Defense Operations Budget Designation. We looked at how budgets are made in Washington, and I lived this for 8 years as the CDC director, and it's painful. There's something called the budget dance, and what actually happens is, from a good idea, you get chopped and chopped and chopped, and then it gets chopped again, and then it gets sent to Congress, which ignores it and bases their budget on last year's budget. So what we proposed was a new funding mechanism that was exempt from the budget caps, but discretionary. There is one prior example of that. There were criticisms of that example as being a slush fund, so we put in ways to address that criticism, and we also tied it into another mechanism of having the scientists actually do what's called a bypass professional judgment. It bypasses the Office of Management and Budget. So do not pass OMB, do not get cut $200 million. It got some traction, bipartisan in Congress. But again, it's about how can you get a policy through that's good for everybody a lot, but doesn't have any major force pushing it.
Right. Well, this goes back to Jim Wilson's point, I think, and maybe in the aftermath of the pandemic, I think I can tell you that my undergraduates over the last 5, 7, 10 years have gotten increasingly interested in global public health. I mean, 10 years ago, I don't think I had any undergraduates who would come to me saying, I want to work in global public health. Now it's very common. Maybe it's because they know who you are, but I actually think there's a lot of interest in global public health and in public health more generally. So going back to Jim's point, politicians do respond to political pressure, and that political pressure can come from the public, doesn't have to come from industry or lobbyists, it can come from the public. So it seems to me that part of the answer is to ensure that there is a constant stream of pressure coming from civil society to do the right thing with respect to public health, whether that has to do with vaccinations or sanitation or pandemic preparedness.
I think that's right. And the way I think of a successful public health program needs to have technical excellence so that if you do what you're intending to do, you get the right results, operational excellence so that you have good management, and political savvy. And if you don't have those three things, you're not going to get the results that you want. And that's true whether it's COVID or tuberculosis or tobacco control or road safety or gun safety.
Right. Jonathan's going to want to take us to Q&A soon, but I want to get to one final dimension that we've talked about and I think is in a lot of people's minds, which is the international dimension. It's pretty clear that global public health is something that concerns everyone. Microbes don't know where the borders are, so protecting yourself from an infectious disease without worrying about what's happening in the surrounding countries is pretty foolish. And we do have a lot of successes. In fact, I have a colleague who has written an essay which uses global cooperation in global public health as an example of the easiest kind of thing there is to get international cooperation. It's very hard to get it in the economic realm, but there's been global public health cooperation for 150, almost 200 years. And there are a lot of successes. The WHO has had a lot of successes. We've just heard about polio eradication in Africa, smallpox, TB, but it's become controversial. So what are, in your view, the concerns, both the legitimate ones and perhaps the not legitimate ones? What's going on there, and how should we think about the role of the WHO?
Well, I can speak to this as I was actually seconded or loaned to the WHO for 5 years. So I worked within the organization as a CDC employee for 5 years. And I have a good view of its strengths and its weaknesses. And as with many organizations and many individuals, often your greatest strength is the same as your greatest weakness. And WHO has had a lot of real successes. The one that is often pointed to is smallpox eradication. Smallpox killed hundreds of millions of people in the past century, and it's gone from the world forever, such that we don't even need to get vaccinated anymore. That's a remarkable success story. And interestingly, that was done at the height of the Cold War, when the US and the Soviet Union could actually make health to be a safe space, to a bridge to peace. And something similar was done in the 1980s. A very nice story from UNICEF, actually, another global health agency. There was a big push to get to 80% childhood vaccination. Jim Grant was a wonderful UNICEF director, and he would have calls every month with all of his country directors. You know, what's your level of vaccination now? Why hasn't it gone up? And this is the kind of management and information system that's needed. And his poor country director in El Salvador said, well, we're not going up at all because we've got a civil war. And Jim Grant said, well, stop it. and they did. They had días de tranquilidad, and they had both sides agree to days of tranquility, when both sides would almost compete to see who could vaccinate a larger proportion of the kids in their side of controlled territory. So health can certainly be a bridge to peace. And as you say, we really are bound up together. If a virus or bacteria emerges in any part of the world, it can threaten any other part of the world within a day or two. We certainly have seen this in COVID, but it's true for many infectious diseases. So there's a global commitment and really obligation to support the World Health Organization. WHO is essential. It's a necessary condition for collaboration, but it has weaknesses. It is a representative organization, and therefore, when it recommends something, generally a lot of countries get on board. On the other hand, it's a representative organization. So it can only recommend something when everybody gets on board. And that is a very limiting dynamic. Now, how that might be changed post-COVID, we'll have to see. I think we have to be realistic about what can be done beyond the role of assessing and helping. There's a need to dramatically improve global preparedness. There have been a lot of big global health successes in HIV, TB, immunization, malaria. There hasn't been that kind of commitment to public health preparedness, and that should come out of COVID. It's unlikely that that would be hosted solely at the World Health Organization, but they'd be an important part of the solution there.
Right. Well, in some ways, the advantage of the WHO is that it stands for a politically uncontroversial and generally desirable goal. And the disadvantage is that it's political. And that, that's the kind, we see that in, of course, domestically as well, that the disease control is both apolitical and politicized, unfortunately. But that's the reality. So maybe we can end, I'll ask you the question that we ask each other usually every Thanksgiving, which is, what's the best way to improve public health?
Well, I think it goes back to really Wilson's approach. You need an effective government, a good public sector. You need an activated civil society, and you need an information system that's going to keep people honest and let us know how we're doing. Because the fact is, if you look at the US, we are doing terribly in terms of our health status. And this isn't Democratic or Republican. This is going back decades. If you look back to 1980, we weren't such a global laggard. But since 1980, over the last 20 years, our life expectancy has fallen in comparison to other OECD countries, and our health spending has increased. In fact, there's a really pretty good negative correlation. You might suggest that it's even causal, though I don't think that's the case. But it is the case that we're not spending our health dollars well. And because of that, we're not getting health outcomes that we deserve. Right. Years ago, I wrote an article, Healthcare as if Health Mattered, because we don't really set health policy with the goal of maximizing health. And whatever happens with COVID, I hope we'll come out the other side saying we're going to commit to strengthening public health in the US. We're going to commit to strengthening public health globally. And we're going to commit in the US to having a much better health system that delivers health, including a strong primary care system, where the US has a very weak system in general, with some notable exceptions.
One thing first, I know this is painful, but 1980 was not 20 years ago, Tom. It was 40 years ago.
I said 40 years
okay,
ago.
Good. But the way I would summarize, in a way, what you're saying is that on the one hand, the problem is that public health is the responsibility of politicians that don't really have strong incentives to provide it in the way that people who believe in it think it should be provided. That's the bad news. But I think there is good news, and I would want to at least end and then go to questions on this note. The good news is that politicians do respond to political pressure. And so to the extent that Americans and others put pressure on their elected representatives to do something about public health, there will be a response. Right? The business community wanted New York's water to be cleaned up. It got cleaned up. People in New York wanted tuberculosis to be managed. It got managed. So political pressure coming from the public, coming from civil society, does have an impact. And I think that's the good news, because otherwise we would just say, well, politicians only think about the short run. They'll never solve this problem. That's not true. There have been many long-term problems that have been solved, and this is one of them. We have resolved some of them, but others remain to be addressed. And I think the fact that people are now concerned about public health, both globally and domestically, is a step in the right direction. And I think we can now go to Jonathan, who I know is chafing at the bit to give us a bunch of questions from those who have been patient enough to listen to us for over 40 minutes.
Very good, Jeff and Tom. Thank you so much for that. And let's start with, you've talked a lot about neglect, misspending, inattention. How about outright resistance? This is a pandemic that has seen resistance to public health measures, but it's not the first pandemic nor the first time there's been resistance. So what's different now, or what's similar to where resistance is coming from?
Well, I think it is really unprecedented. We've seen resistance at times, and it generally occurs when, for example, there's distrust of the government. So one of the reasons that the more recent Ebola outbreak in the DRC took so long to control is that it happened to occur right in the center of an area where there's a lot of friction between that area and the central government. So the central government couldn't get in safely, people were shooting at them, and they didn't believe that this was really a pandemic, an epidemic in that case. This is so extraordinary because you have the federal government really not communicating consistently. You have the effort to downplay the importance of it, leading into a suspicion that, there's some ulterior motives or it's being overblown. And I think one of the challenges is that the accurate nuances get lost. There's so many false dichotomies here, open versus closed. We were never fully closed, and we're not going to be fully open for a long time. It's more like a dimmer dial. Aerosol transmission versus droplet. Well, it's actually a continuum. It's not an either or. Masks or not. Well, it's a question of using them in the right place and in the right way. And in the same way, is it a catastrophe or is it overblown? Well, it's neither. It's a really serious pandemic and it's deadly for certain people, but it's also quite mild for a lot of people. And that kind of nuance makes the messaging really hard. And I do think that the communications from the White House have made it more difficult for public health people. The pattern set with the White House and the CDC then played out in many state houses and cities and counties. But it's not just about the White House. It's also about where we are as a society. Again, epidemics tend to prey on the fissures in society, the vulnerabilities, and the partisanship that we have, the anti-science that we have, the lack of a clear authority and the questioning of authority. I saw it on Twitter, so it must be true, versus, this is someone who's worked 30 years on this, and they're telling you what we know, what we don't know. And we've seen a lot of these kind of pop-up experts who have limited experience, but they speak with great certainty. One of the things I've emphasized to people is that for some of the controversial, complex issues of COVID, if you hear someone speaking definitively about it, it means they don't know enough about it.
Well, just to build on that, I think that the resistance and the way that this has played out politically is a result of and a reaction to the pre-existing polarization. I mean, the country was already politically polarized. And as you say, Tom, the virus and almost everything else has preyed on the weaknesses. And this is the polarization of the country is clearly a weakness. When we think about vaccines, and I know we've talked about this, think about a vaccine, one of the reasons there's such concern about making sure that the vaccines are safe is we already have a group of anti-vaxxers out there. And now we have Democrats saying that they won't take a vaccine because they don't trust the administration. Well, so the polarization really is at the root, I think, of a lot of this. In a way, the bizarre response to COVID is the result of pre-existing conditions, which is the politics that the country has been undergoing for the better part of a decade.
You just wish that we could be really clear. There is an enemy here. There's only one enemy. It's a virus. And the more it divides us, the more it will conquer us. The more we're unified, though physically separated, the more we can win. And so it does seem puzzling from a naive public health practitioner's standpoint, why the government didn't get it more right. But in any case, it's never too late to improve the response. And there's still a lot we can do to save lives and get jobs back.
Well, so let's think about what we can do. You talked a lot about preparedness. How do we get better at assessing preparedness? I mean, preparedness has, as you pointed out, Tom, is based on a lot of social forces and not just a matter of what access to the next flu vaccine. So how do we get better at assessing preparedness?
Well, one way globally is something called the Joint External Evaluation. It's actually a pretty good report card that we developed a few years ago and that more than 110 countries have now gone through this exercise. It's identified something like 10,000 life-threatening gaps in those countries. We get kind of an A or A- on assessment, and we get an F on fixing the problems that were found. So we do have some measures of what works and what's important. They don't fully correlate with how the different countries did in the response to COVID. And part of that is because we haven't figured out a way to immunize our public health agencies against politics. And part of that is because it's not a real-time test. And so one of the things that we need to do better is use the everyday experience of foodborne outbreaks and hospital-associated infections and measles outbreaks as a way of strengthening our systems for finding, stopping, and preventing infectious diseases. And that kind of real-time use of information in the actual world and then improving our responses is a big part of what we can do to both understand where the gaps are and fix them.
So I would say, Tom, that the wise thing to do would not be to try to immunize public health from politics, because that's not going to happen. I mean, public health agencies are creatures of politics, of politicians. The wise thing, I think, is to try to figure out, as we've been talking about, what the political constraints are, how they can be perhaps loosened or tightened, whichever way you think they might want to go, how to work within the political environment that public health faces in the context it faces. I'm struck, for example, we've been talking about polarization and the partisanship, the partisan reaction to the virus. You know, some of the better responses, thinking at the level of states, have been by Republican governors. So it's not a purely partisan thing. There must be something going on that leads people to put aside their partisan differences and think about the broader impact of their policies for the public good. That's not happening enough, not happening at the level of the administration. I would say enough. But it seems to me that the task is to figure out, as your story from Jim Wilson implied, how to work with the politics that we have. Because dreaming for a politics that will never exist is not going to take you much of anywhere.
Well, Jeff, let me build on that. Is electoral politics a constraint? I mean, are we, based on what we're seeing now, are less democratic regimes going to be more effective in the next public health crisis?
Well, the problem with an authoritarian regime is they'll be able to do whatever they decide to do, you know, with authority, that if they're in fact authoritarian and authoritative within their borders, but they could get it right, dramatically right, or they could get it dramatically wrong. So you sort of takes your pick. The good thing about a democracy is that it is, in one way or another, subject to the constraints of the public. Now, we only get to vote every once in a while, but politicians are constantly trying to take the pulse of the public. And that's why I think what Tom has said, and what political scientists, I think, would also emphasize, that concentrated pressure from people who care about these issues will make a difference. You can see it in other areas, like, you know, the environment. 50 years ago, there were no organized interests dealing with the environment. Today, Europe is rife with them, and the US as well. So public health is a little bit like the environment, and there's no reason why there couldn't be as much political pressure on policymakers in the public health realm as there is in some other public goods, like education or the environment.
And if you have an authoritarian regime, you may not know what's happening because you don't have the press, don't have independent agencies, and therefore you may actually do less well in some ways. And as Jeff says, if you get it wrong, you get it really wrong. I guess one way of immunizing public health agencies is to have that kind of a strong defense of civil society that will stand up for public health. But it's hard because it is such a conceptual thing rather than a concrete thing.
Well, it's nebulous until it's not, right? It's nebulous until you have to take your kids out of school and shut down your city and have 15% unemployment because of a virus. And perhaps the experience of the last 6 months, and unfortunately probably of the next year or so, or however long it lasts, may lead people to pay more attention to these issues. I certainly hope so. There have been crises of other such public goods before, like the environment, that have mobilized public opinion in ways that have lasting effect. And that, I think, would be something to hope for.
Let me actually, and this will unfortunately be our last question, let me just build on that. To what extent are you seeing, first Jeff and then Tom, the opposite? You talked about the crisis of the environment and how that makes people think about other kind of crises. Are you starting to see the reverse? Are you seeing the thinking about the pandemic as a global experience also making people think about other kinds of crises such as climate?
I think that, you know, Tom keeps saying we're all in this together, both domestically and internationally. I think the fact that no matter what we try to do, we're going to be affected in this pandemic by what happens in the rest of the world is getting home to people. Interdependence, globalization, whatever you want to call it, is a fact now. Now, I know there are some who would like to unwind that fact, but major aspects of it can't be unwound, and one is the disease environment. So I would hope that people have become more aware of the fact that the world is tied together in ways that in many ways are unprecedented and probably aren't going to be reversed. and that this raises a whole new host of questions and problems for us that we have to address. We can't just ignore them. We can't just say we're pulling out of the WHO because we don't want to deal with global public health. Global public health, global disease issues are going to be with us whether we're in the WHO or not, whether we want to or not. And I hope that there's been a greater understanding of the extent to which the world is really tied together, both with respect to the environment, climate change, and with respect to disease and public health.
And I think that's really the point to end on, that if there's one thing that gives me some grounds for hope and optimism, it is that this terrible pandemic will drive home the fact that we are all connected, that our fates are bound up in really important ways. That that ranges from if a college kid has a party and infection spreads, that may kill someone's mother, to if a country isn't doing a good job controlling infectious diseases, that might create the next global pandemic. And that means that we all have both mutual dependency and mutual accountability. And what we hope within the US and globally is that we'll use that to figure out ways that we can work together, discover ways that we can be safer, healthier, more productive, because that's possible. That's a future that we can embrace. That's a future that's going to be more economically productive and where people will be living longer and healthier lives.
Well, thank you, Tom, and thank you, Jeff. And thanks to all of you who have joined us tonight. We hope you'll join us again soon for our next signature event. Information on upcoming events, as well as recordings of past ones, and soon this one, can be found at socializeremotely.harvard.edu.